So next I'm going to talk about an abstract that's actually from my group. It's about progress in early stage lung cancer among economically disadvantaged patients. This is a question that we really wanted to tackle. There's been a large body of literature that describes how patients of lower socioeconomic status have worse outcomes with lung cancer. We all know that there's probably several reasons for that. They may seek care later. There may be financial or social concerns. Many may be more likely to smoke, and this is particularly true in developing countries or in urban areas, minority populations. And once they're diagnosed, perhaps these patients might not undergo as rigorous of staging. They might not get molecular testing in advanced stage disease, and they may be treated at low volume hospitals or by low volume oncologists. There's just so many possible reasons why these patients do worse that I'm really proud that groups like the WCLC and others have really put a significant number of resources towards understanding disparities and towards addressing disparities when it comes to treatment of lung cancer. But that's not really the message of our abstract. We really wanted to know where are we starting? How low is the floor, and have we made some progress? Certainly over this amazing period of time in the lung cancer community, we'd like to see that even our most at-risk patients are doing better. And so that's what we sought to do here. We divided patients from the National Cancer Database from 2004 to 2014 into quartiles based on income. And we specifically looked at the lowest income quartile. That's the group of patients whose income was less than $38,000 a year. And then we divided the study into different time periods to see, have we made improvements over time? And I think many of us would love to see that we're not just helping the select few who have access to drugs, access to best care, but that we've lifted up the whole lung cancer community. And I was really proud to see that, in fact, we do see that in some of the data. In that quartile were over 45,000 patients who we looked at. Many were from metropolitan and urban areas. 3/4 had stage 1 clinical disease. We only looked at clinical stage 1 and stage 2. And the median age of these patients was 68 years old, and about half were women. Many were treated at academic centers, about 40%, but many were treated out in the communities, as we would expect. And we saw some good and bad. I would argue that some of the bad is that there was still a high proportion of patients who got no treatment, about 13% of patients for whatever reason. Less than 60% received surgery, which most of us would consider standard of care for early stage disease. You could argue maybe some shifted to stereotactic radiation, but only 16% got radiation only. So that left a lot who were getting no treatment, chemoradiation, chemo alone, these things that we wouldn't necessarily consider guideline-based care for clinical stage 1 or stage 2 cancer. Clearly, we have some work to do. The good, though, is that several trends suggest that we're going the right way. The rates of no treatment decreased over the time period from 15.1% to 12.2%. Doesn't sound like much, but clearly I think we're doing better. We're offering treatments to more patients. The use of surgery increased 6% over the time period studied. So patients are starting to get more referred for surgery, even those of lower socioeconomic status that we studied. And probably the most important data points are how these patients did. 30-day mortality decreased over the time period studied, and 90-day mortality decreased over the time period studied by over 1.5%. So we're doing better surgery, even for our most at-risk patients as time has gone on. I was also happy to see that readmission rates decreased from 4.9 to 3.3%. And then really the bottom line for patients is survival. Because we looked at earlier and later time periods, we couldn't look at longer term 3- and 5-year survival, but we started to get a snapshot of what was happening by looking at 1-year survival, 2-year survival. Certainly we would have high expectations for such a short survival time. And we were happy to see that for these patients of at-risk socioeconomic status, the 1-year survival increased from 74% to 83%. The 2-year survival increased from 57.8% to 68.3%. So a pretty marked increase in a relatively short 10-year time span. This just gives me and gives others interested in disparities great reason for hope. I think as often we like to do also, we tried to see, are there predictors? Can we predict which patients of lower socioeconomic status do better? That's important because then maybe it's scalable. We can expand it to other groups. Well, females had a less than 25% decrease in mortality. We can't change that, but it's interesting to know. Treatment at academic centers decreased your chances of dying by 7.4%. Patients with private insurance, and maybe better insurance, we all know that it probably makes a difference. Decreased patients' chances of dying by 15.8%. And the use of surgery decreased the chance of dying by 51.3%. So again, I push for considering all these patients for surgery, right? Socioeconomic status shouldn't be a barrier to surgery or to any treatment. And the message that we wanted to get across in this abstract is that, number one, still work to do, but number two, we're doing better. And I expect that we'll continue to do better with leadership by groups like the ASLC.